I'm Liz Flannery. I'm the Director of Education and Leadership at American Institute of Dental Public Health. I am a white woman with light brown curly hair, and I am thrilled to be here with everyone today. Thank you for joining us for our very first collaborative training webinar. Today, we're going to cover a community-led approach to increasing dental benefits in Medicaid, a Texas case study. And we're going to kick off with a few housekeeping notes. Closed caption and live transcript have been enabled for this session, but I do want to note that those are not always 100% accurate. If you have a question about turning those on your end or other Zoom questions, please post those in the chat and a staff member can assist you. Live captions currently don't work within breakout rooms, only the main Zoom room. We will be doing breakout rooms later in this session. And so if you need to remain in the main room and you get a breakout room, please just ignore your invite and you can stay in the main room for that closed captioning capability. Closed captions are available on Zoom iPhone and Android phones, but live transcript is not. This session is being recorded, so please stay muted until you're called upon or we're in those discussion session pieces. If you have a question that comes up during our presentation, please post that in the chat. Slides, forms, and materials will be available on the AIDPH website after this event. Please type your email and organization in the chat to introduce yourself. And I said before, if you have any questions about Zoom, please post those in the chat as well, and a staff member will assist you. Okay. So before we fully get into our content, we want to take a moment and thank the funder of this program, CareQuest Institute for Oral Health. This is a collaborative program between American Institute of Dental Public Health and the Coalition of Texans with Disabilities, and again, funded through CareQuest Institute for Oral Health, and we thank them for funding and supporting this program. So the things that we're going to cover today, I'm going to give a bit of an introduction to what this program is all about and American Institute of Dental Public Health in general. Dennis is going to lead us through a case study presentation that really gives us some great material on successful advocacy. And then we'll go into breakout discussion and work as a group together to talk through some of these issues and end with next steps and what we can do next. This slide covers American Institute of Dental Public Health, our mission and our vision. I'll read through that now. Our mission is empowering our community to advance oral health through science, education, and advocacy. And our vision is a justice-oriented oral health system. We work towards that vision through our mission, focusing on science, education, and advocacy. And that's what we're doing here today, which brings us to American Institute of Dental Public Health has 4 communities of focus. These communities, when we're looking at that oral health system and ensuring justice there, we're working with communities that have been traditionally excluded or marginalized, and that includes rural communities, veterans, LGBTQIA+ people, and people with disabilities. So a little bit more about this program specifically. Strengthening state Medicaid advocacy for people with disabilities. This slide outlines what this program is. We have 4 components here with 4 icons listing out the components of this education program, and I'm going to read through those now. The program consists of training webinars, which is what we're doing here today. This is the first part of a 4-part series of training webinars that will be virtual sessions sharing real-time successes and strategies for building relationships and advancing legislative action. We're building out an advocacy toolkit, which is a step-by-step guide for advocacy efforts, including templates, research, scripts, sample legislation, and more. We're also building out a bill bank, which will contain sample legislation for state-based stakeholders to review and replicate in advocacy work. And we're providing continuing education credits. Oral health professionals can request CEUs for each training webinar that we do here. And I think the most important thing to note is as we are building out these pieces, and bringing them to the community. We want to hear from you, everyone that's on this call today, other folks in your community, what is most helpful to be included in the pieces of this program. The training webinars, the advocacy toolkit, and the bill bank. We have a few different ways of capturing that information from you. As I said before, we will be doing breakout room discussions during this session. And so if you have ideas about what's helpful to include in these pieces, we want to hear that today. We'll be recording our breakout room discussions so we can capture that information. Part of gathering the continuing education will provide a link where you can request your CEU credit at the end. There's also an evaluation on that link. So even if you are not interested in a CEU credit, please take that link and fill out our evaluation. There's spaces there where you can provide information and thoughts on what is most helpful as part of these tools. So what we're going to cover today, this slide has our learning objectives, and Rahel is also going to pop those into the chat for everyone to have access to there. By the end of this session, participants will be able to analyze the process for identifying gaps in Medicaid dental benefits for adults with disabilities, evaluate the steps involved in determining a legislative solution, including stakeholder engagement and policy analysis, explain the significance of community advocates leading health policy initiatives, emphasizing their role in championing for marginalized populations, and apply lessons learned from the Texas case study to propose innovative solutions for improving dental healthcare access in other states. Our presenters do not have any conflicts of interest or disclosures to share today. And without further ado, I'm going to stop my slide share and hand it over to Dennis from Coalition of Texans with Disabilities to give our case study. Dennis is the Executive Director of Coalition of Texans with Disabilities, and in that role frequently works with the Texas legislature and state agencies on issues surrounding disabilities. He brings over 40 years of experience working in nonprofit organizations and advocacy, and has successfully advocated for positive change in government policy and practice in employment, transportation, housing, healthcare, and architectural barriers to promote the full inclusion of people with disabilities in community life. So Dennis, please take it away. We're very excited to hear from you.
Thanks, Liz, and I'm glad to be here, honored to be here. Yeah, I'm just Dennis, okay? You know, as a disability organization, we always like to do the audio description, which Liz did beautifully. I'm an Anglo male. You heard I've been around for 40 years doing this, so it won't come as a surprise that I have gray hair and a gray beard. And I'm here in my office in Austin, Texas. I have a jacket, dark jacket, white shirt on. This has been, and this is not an exaggeration, this effort was one of the most meaningful advocacy successes in my pretty long career of doing this stuff for a highly disadvantaged population. And I want to second what Liz said too. She mentioned CareQuest, who is supporting this effort right now that we're doing in partnership with AIDPH. And frankly, we would not have gotten to this without the support of CareQuest through a fairly lengthy process. So having said that, what we're going to do is give you a chunk of the case study in Texas. And in the future, in future webinars, we'll follow a timeline and how we advance this. Nothing happens with the snap of your fingers in the Texas legislature. My guess, your legislature may not be the same. So having said that, okay, why did we do this? Well, first of all, you got the idea of the Coalition of Texans with Disabilities. We are a statewide, what we call cross-disability advocacy organization. That means all people with disabilities from birth, intellectual developmental disabilities, sensory disabilities, mental health issues, age-related, injury onset, whatever, until end of life. So we cover it all. And we've been around for, incredibly enough, 46 years. We're one of the oldest cross-disability state organizations in the United States, of which there are only about 3 other peers. So there are many disability groups, but few that have that cross-disability focus. So how do we get on this? You know, I work with people with disabilities. My board members are predominantly people with disabilities. Our members, of course, are overwhelmingly people with disabilities. I socialize with people with disabilities. And you know what? It doesn't take much of a dawning to, as you're around these folks, determine what their oral health is. It's obvious. There are missing teeth, broken teeth, very stained teeth, some with no teeth whatsoever. And it doesn't take too much to say, well, why is this? And you can kind of go to the answer that, well, people with disabilities, maybe their self-care isn't very good with their oral health. They have trouble, brushing, flossing, or if they have an attendant helping them, they're not doing that good a job. Well, those may be factors. But as you start going in a little deeper, at least in Texas, what we found out, and there are other states like this that have either very limited or no access to a dentist in the entire adult lifetime of an adult with disabilities on the state Medicaid program. Think about that. We all know what a dental visit is. What if you were told you could? I'm sorry, that'll never be your care plan to see a dentist once you turn 21. If you're a child, yeah, you can do it, but adult, no way. So if it's going to be a Medicaid issue, then you got to start thinking, how can we solve this? And you know what I started hearing early on, and if I'm going to raise my hand a little bit here, what I'm doing is I'm sprinkling magic dust. And why I would hear people tell me, well, somebody else will solve that problem. And after a while, I started calling these magic dust solutions. And here's my first solution. I'm going to sprinkle some magic dust. I'm going to call it the faith community is going to take care of this. The churches, the faith community. And by the way, every one of these I mentioned, there will be individuals that will get some care and will benefit. But I will tell you, there were 450,000 adults with disabilities in Texas in Medicaid that had no access to a dentist in their care plan. 450,000. So those churches, we're going to sprinkle that magic dust. No, they will help some. Well, the dental profession will do this. And would you put up that chart, please, on the number of dentists in the United States? This is one we'd hear. Well, dentists will do pro bono work and take on individuals with disabilities and treat them pro bono. Once you're here, this chart here, this is the most recent data we have. This is for the entire United States, Now, as you can see, through 2016, there's under 200,000 dentists in the entire United States, okay? Now, who knows how many of those are in corporate dental businesses or other kinds of things where they have little control over what they can do, but a lot of them. But like, I have worked with dentists here. I'm going to have an interview with one a little bit later who will take on about 2 pro bono adults that they can handle with regular dental care. So let's say that this would never be the case, but every one of those 195,000 took on 2 adults pro bono. They would not even be able to cover the demand in Texas alone. So you can remove this chart here, and that's another little magic dust thing that will help a few people and helps them a lot, make no mistake about it. But does it deal with the scope of the issue? The other one I hear is, like the local Capital Area Dental Association does a dental day, 1 day a year, where they'll get a bunch of dentist chairs and they'll get a hall and a bunch of their members and the public who can't access dentists will come and get some care. Now, it's not just people with disabilities. It could be people who don't have any kind of dental insurance or have any other access, general poverty. So again, that's magic dust. It's not going to deal with the problem. Will those people be helped? Yes. Is it a bit of a solution? A very minute one. The other one, foundations, charitable foundations. We have one here in Texas that operates a dental program where they have mobile dental vans that go around. And it's a great program. 90% of the people they serve are children. Only 10% are adults. And they're all poor adults, not necessarily adults with disabilities. So again, more magic dust sprinkling on the solution. The last one, the 5th magic dust solution, this is one I hear. don't worry about it. I'm going to sprinkle this magic dust on this person in extreme dental pain and tell them they can go to the emergency room. And they can. Remember, hospitals cannot turn away people, whether they have any coverage or not, even if they don't have coverage through Medicaid. But you know what? There are no dentists in the emergency room, none whatsoever. So they show up there with extreme dental pain, and what do they get? Why, they get an antibiotic to knock back the infection, and they get a painkiller. And I'll tell you, until the last 3 or 4 years, the main painkiller that people in severe dental pain got in the emergency room were opioids. Opioids, the very thing we're trying to, reduce in our society. We were using that to care for people in extreme dental pain. Not a great idea. Okay, so those are all the magic dust solutions. What's the solution? Change public policy. Make a dental visit part of the Medicaid care plan. Okay, so that takes us to, okay, that's our solution. We've figured out how to get to that solution. Now, how do we decide our step on how we're going to take the next approach? First of all, you have to think about your unique state. And this is a state legislative issue. While Medicaid is a jointly funded federal state program, a lot of the decisions are made on the state level. So I'm going to talk about Texas, some of the unique landscape in Texas. For one thing, we never use the word expansion. Notice the title of this program didn't say expand to more dental services. Medicaid expansion is not popular among policymakers in Texas. They've never taken it. In fact, it's almost like a poison pill. So don't say expansion. In Texas, they don't like to accept any federal help. And when they do, they like to hide it. Okay. And that's just the way they are. In fact, they fight more with the feds than they collaborate. Texas ranks 49th in public services to its citizens with disabilities. They're not a high services state for any economically disadvantaged populations. We're also a state that is dominated by a single party. That can create problems too. And finally, we have limited legislative sessions, 5 months every other year. So I could tell you that these are all just characteristics of Texas. You have your own in your own home state. And I could say, well, let's moan about that a lot. But instead, what I'm going to tell you is you can have success. Instead of avoiding these characteristics, make your advocacy relate to those characteristics and barriers. Okay, so we think we can do that. Now we're going to have partners. We're a nonprofit organization, small number of advocates, not many resources. So there are interested parties. So how do we determine getting those parties involved? And I'm going to talk to that in a future session too. But we know, for example, managed care organizations handle a lot of Medicaid in Texas, but they would not be a good in the lead position. Why? Because it would be perceived as having a profit motive in this kind of advocacy. In fact, the dental trade associations are in a similar boat. If they advocate for more Medicaid or access to Medicaid dental, they say, well, you're doing this, not because it's right, it's because you want to have more patients, more clients, more revenue. There's also another group, what I call the hired guns, the contract lobbyists who will work. And, they can be helpful. In fact, all these groups can be helpful. But again, contract lobbyists are perceived as, well, you're hired to do it. You may not be a sincere, true believer on what you're doing. So who does that leave? Why, that leaves disability advocacy organizations. And our issue there is we don't have a lot of resources. But by partnering with these other groups, we can share resources and make it happen. But it was very important. I was told very early on that if we're ever going to pull this off, it had to be an advocacy organization that's representing the intended beneficiaries, not the healthcare professionals, not the managed care organizations, not the trade associations. It had to be those who represent the beneficiaries. We don't have a profit motive. I mean, it's ridiculous. Sometimes honest advocacy can be derailed by such charges. It really is. But that is the way it is in Texas. So with that, I'm going to ask to run our interview I did with Dr. Jeff Brunson. I hope my timing's good, Liz.
Yep, that's great. I will share my screen here. And I just wanted to share a note for folks using closed captions. It should work with this video. However, it will show up as my icon, not the folks speaking, because it is a video recording. Sorry, 1 second.
So hi, I'm Dennis Borrell with the Coalition of Texans with Disabilities. I am an Anglo male. I have gray hair, a gray beard, and I'm wearing a light blue shirt. And I'm here to welcome Dr. Jeff Brunson to talk a little bit about dental services for adults with disability and Medicaid. How's it
Sure.
going, Jeff?
It's going great. My name's Jeff Brunson. As you mentioned, I'm a dentist. I have my own practice at Brunson Dental. I'm an Anglo male with very short, almost no brown hair, and a gray beard and a gray shirt to match.
So neither one of us are spring chickens, but
No, we're not.
we've been around the block a few times. So I've known Jeff for a long time, and in the last several years, we've taken our friendship to the level of advocacy for people who too often don't even get to see a dentist in their entire adult lifetime. So thank you for doing this today, Jeff. And I have a few questions I'd like to ask you. And let's start with you're a Texas dentist, and you got involved with advocacy to add access to dental services for adults with disabilities and Medicaid. Why did you do that?
Well, I just feel like it's the right thing to do. From the time I was in dental school, I was doing, foreign mission trips to, been in Mexico and Panama, and, and then you turn around, you see the needs right there in your back, in your backyard. And so it was natural, and it seemed like, again, the right thing for me to do to advocate for these folks that don't really have much fighting for them.
And to be sure, you hadn't really gotten involved too much in public policy prior to this, had you?
Well, not, I mean, kind of yes and no. I mean, as a dentist, I was previous dentist of the president of the Capillary Dental Society, and we've had to do some advocacy at City Hall for like water fluoridation. But at the state level, yes, this is my first experience.
Okay. So what would you tell a fellow dentist about working with people with disabilities in your dental clinic? What would you tell a fellow dentist who doesn't have any experience in that?
Well, I feel like we do get a little bit of experience in dental school. So I think what I would tell a young dentist, or maybe somebody interested in a career in dentistry, is that, this field has always, you know, tried to be prevention. A lot of people are just trying to sell you a product, and in the medical field and specifically dentistry, I mean, everybody's heard of, brush your teeth, floss your teeth. You don't have to go to a dentist to hear that. And all those words and that, that push came from within the profession. Our profession does give us a lot of opportunities, things called TMOM, Texas Missions of Mercy. It's not just in Texas, they're nationwide now, where you get a collection of dentists in one area and provide treatment to folks that couldn't otherwise afford it. It's not specifically for the folks with the disability, although there are folks that are there. Those mobile treatment situations don't quite have the sturdy equipment that we have in a traditional dental office. So, unfortunately, I think there's not as many folks that are reached in the disabled community as I wish we could. So once I got to know you, and you introduced me to, the plight and the fight too, I wanted to be a part of it.
I noticed you mentioned, and that's great. And I noticed you mentioned like the mobile clinics are they have limited resources. And I'm gonna jump ahead a little bit. You know, in this issue, we're in our state alone in Texas. And by the way, this is a national webinar we're going to show this interview on. So there are a number of other states that provide no dental access to adults with disabilities and Medicaid, or very limited. Um, in Texas, we have passed legislation to do that, and we're still waiting to implement it. But when we first started talking about this, we had people tell us, well, there's other solutions. You don't have to go to public health to literally pay for, if you will, pay for dental services. And one was all these mobile clinics. Well, another what I call a kind of solution that isn't a solution is they say, well, the dental profession, they should just solve this problem by simply agreeing to take on and serve low income people without charge. And I would, before you answer that question, in Texas, there were 450,000 adults with disabilities in this population. So do you agree or not that the dental profession could simply take on these services pro bono? And what's your thought on that?
Well, just the sheer numbers is the issue. I honestly Googled it today before we started talking. How many dentists are there in the state of Texas? And there's 15,000. So you can do the math on that pretty quickly and know that just giving away or doing pro bono services is not going to match the 450,000 that you mentioned. On top of I remember one of my professors in dental school would say, you guys are getting free, you're getting free pizza at lunch, but there's no such thing as free lunch. Somebody somewhere is paying for it. And, I've certainly couldn't absorb, days and days without also having to keep a business afloat as well. So, and I'm in a unique position that unfortunately a lot of dentists don't have these days. And I work by myself. I don't work for somebody else. I don't work for a corporation. So I have a lot more flexibility to help people that some of my colleagues, unfortunately, just don't have that opportunity. And it's going more and more that way to where fewer dentists own their own practices and operate the way that we're kind of used to the dental model. It is definitely changing.
Yeah, even someone like you, if you will, like your sole practice, your sole clinic, I know you're pretty busy. There's a limit to what you can do. So what would be about how many, let's just say, how many typical adults could you take on as regular pro bono clients and be able to afford to do that? What would be a reasonable number for a practice like yours?
That's something I probably would need to give more thought to. Uh, if you set aside like an hour a day, so roughly one patient a day, 4 days a week, 50 weeks out of the year, I think that would certainly be manageable. But the when you're treating folks with disabilities, typically the same procedure does take longer. So there's just a lot that goes into it. So I don't really know that I could give you a great number on what that would be. So sorry on that.
Yeah. Well, I'm just thinking that, with 15,000 dentists, and let's say there's maybe 5,000 that have the capacity to take on pro bono clients. Maybe not even that if they're in these, larger practices. And each of them, so that's 5,000, even each of them maybe took on 10, that's maybe at the outlier 50,000 out of the 450,000 adults. And to be sure, that's very important for those who get the service, but it doesn't address the problem. That gets to another one of these solutions. They say is, well, you mentioned you were a dentist of the year in the Capillary Dental Society, and you've been do these like a dental day where a bunch of dentists get together and they get a site and they invite the community to come in for a day. Is that a reasonable solution for a problem this big?
I don't think it's a solution, but I think it can be part of it. I definitely think it can be part of it, but it's the overwhelming numbers, and then the just logistics of getting everybody to one site is not an easy task either. So with the team moms that I mentioned earlier, they've been very effective, and they treat thousands and thousands of people every year pro bono, but that doesn't meet really the full needs of the community. And I shared that book with you that talks a lot about how dentistry was kind of separated from the healthcare model. And it will, I think I know why, but it will always be interesting to me that if you have a toothache, you can go to the ER, but there's really no treatment that's available for you. And that's that's the safety net. Is you have to wait till your tooth is infected, you're in so much pain that you have to present to an ER to even get an antibiotic and maybe something, you know, for, you know, to make you comfortable. So that's not really a good safety net, because, you know, most likely when you're in that situation, you're probably losing a tooth, if not more. Hopefully it can be saved, but probably not. And then as you start to lose these teeth, then you start to put more wear and tear and strain on the rest of your teeth, and everything starts to break down. You know, I always kind of, you know, compare the to the mouth. It's a machine, it's a chewing machine. So just like any other machine, the better aligned the parts, the less friction, the less breakdown, just the longer things last. So you start, you know, again, going back to the engine model, you know, you start taking out a piston, and now 5 of your pistons are having to work harder to make up for the one. So real simple analogy, but you know, there's just not a good safety net. And some of the individuals that, you know, you've introduced to me over the years, like, they make my day, you know, when I see them and I have that opportunity to help them out. And it's a small thing for them, but you know, it's a big thing for me, because I really enjoy those opportunities.
Yeah, and I can tell you, having spoken to the patients you've worked with, that they revere you, and I think they would revere anyone doing that. I guess we've touched on most everything I wanted to talk about, but I I wanted to add that you know, in the past we've discussed that we've looked at health economics models which show that in fact you don't save money by ignoring a preventive dental program for people who can afford it. And if you're paying public health dollars, you're actually better off doing dental prevention care. Is that would your opinion match that?
Oh, absolutely. I mean, there's no doubt that, you know, when you either prevent a problem or catch a problem when it's small, you know, the treatment is easier, the treatment is better, the treatment is more affordable. Then, and at the end of the day, the person is a healthier person if you've either prevented the issue or caught the issue at its onset. So
Yeah, and poor oral health can lead to issues with the rest of your body, right?
oh, for sure. I mean, when you think about somebody that's diabetic, they're going to have, you know, higher challenges in keeping, you know, their gums happy and healthy, and that could certainly have impact on their entire systemic health. And again, going back to how the teeth got separated from the body, as far as the healthcare, the way that we look at things in this country is interesting, but it's not really the right approach. But,
It's fantastic. Thank you for your time today,
oh,
Jeff, and your service. I've had a great experience working with you as an advocate and as someone who appreciates care from you too. So thank you very much, Dr. Jeff Brunson from Austin, Texas.
And before you go, congratulations on your successful journey, your long career, and I know good things will continue to come from you. And thank you for this opportunity.
All right. I'm sure
All
I'll
right.
see you soon.
All
Take
right.
care.
Thank you.
Bye.
Welcome.
Wow, that was cool. I had a lot of fun with that interview. I just want to emphasize a couple things that Jeff mentioned. Is he talked about a book he'd given me and about the split. At one time, dentists were considered doctors, you know, originally. And there was what is known as the Great Rebuff, where the medical profession decided that dental care wasn't health care, and they shifted that off with not unlike what they've done with behavioral health back in the day. But we're talking the 1850s, so the idea of comprehensive health care is more important today than ever. He also said another thing I appreciate he mentioned is, you know, he has worked with a couple of our members, and they do love him. And his comment that makes his day. It makes his day. He's paying for that out of his pocket while he's treating them. And yet he finds it. But that's that magic dust. We can't expect that and have a dent in the program. So we are going to go into breakouts right now. And Rahel, if you'll put up that question, I'm going to go through some breakout protocol here and explain how this is going to work. You're all going to be sent off into small groups. You'll be placed in those breakout rooms automatically. You don't need to do anything. Once you get in there, you can do a quick sound check. Make sure you can hear and speak. Somebody should take notes because we're going to reconvene. We want to hear what you say. So, I used to be a high school teacher, and there'd always be those kids in the back of the room that wouldn't say anything. And this is kind of what happens in these Zoom calls. So now you're going to be in a small group, and you can't be in the back of the room not saying anything anymore. Besides, we really want to hear what you have to say. If the staff needs a breakout prompt, they'll get it. And I think Liz or Rahel will send that to you. Feel free to give your audio description as Liz and I did earlier. And if there is a help button and you can ask for help if you're having trouble doing this, we'll have about 10, 12 minutes. This is an opportunity to give us your views. And here, in fact, is the breakout prompt question. Okay, the breakout prompt. What would you like to try to advance dental benefits to Medicaid adults with disabilities? And what have been the barriers? So we're trying to find, what would you like to do? What has been in the way? By the way, notice I say advance dental benefits. We try to stay away from the word expand because, there's still 10 states in this country that thinks expanding Medicaid is a repulsive idea. Of course it's not. So let's go ahead and go into those breakout rooms.
Thank you, Dennis. I'll open them now, and I'm just going to give staff a reminder. Please record your breakout rooms so we can capture those conversations. I think probably, so this is a breakout room for us here in the main room, Dennis. So I think everyone who was going into a breakout room did so, and we'll hold one here as well. So Dennis, I will hand it to you to lead our room and jump in and support as needed. And folks who are here, I would say please, Dennis, correct me if I'm wrong, but jump in, just come off mute, have an open conversation. If you're willing and able, we invite you to come on to camera so we can have a group conversation. And yeah, hand it over to you, Dennis.
Okay, thanks, Liz. I'll tell you what, let's just go by one and say what state you're working in. So Linda Brookman, what state are you in?
Hi, good afternoon. I'm in California, and I'm a white Caucasian female with dyed blonde hair in my 60s. And I'm a dental hygienist. I've taught at a university for 20 years in the USC Dental School and retired a few years ago, but was missing my passion of medical dental integration. And we were doing interprofessional education for a while there with the dentists and meeting with the other medical students and PT, et cetera. So now I have just as of yesterday got my Los Angeles County credentials, and I'm going to be in a medical situation working with children who are of the state. They've been removed, unfortunately, from their parents, that because either they're in jail, they've been, so it's with children, it's not with olders, but they are definitely disabled behaviorally and such. And so I will be in the teaching medical residences about oral health and early prevention, because as we all know, children go in for their well visit checkups to get their inoculations, vaccinations, and the doctor goes in and does an eye, ears, nose, and throat and goes right past the teeth. They don't know what they're looking at. So I'll be working in that capacity. It is a nonprofit funded and county collaboration in this program. So I'm very excited to start next week. It took me a year and a half to get credentialed first through the re-credentialed through the dental school and then credentialed through the county. So it wasn't an easy feat, but I wasn't going to give up.
Fabulous. So Donna, where are you? And Are you interested in getting advancing dental benefits?
Hi, I'm Donna Richards. I'm a dental hygienist. I am wearing a red dress and a tan sweater that you can't see because I can't have my camera on or I will lose everybody. I'm in West Virginia, very rural. I work with Marshall University and also a free and charitable clinic doing clinical hygiene. And West Virginia did pass adult Medicaid during the pandemic. So we have in addition to the emergency benefit, we have an extra $1,000 a year that adults can access for care. Our biggest problem is finding a lot of dentists that will accept Medicaid for payment. So we still end up seeing a lot of them at the free clinic.
Excellent point. Augustine, where are you and what are your issues around getting advanced dental access? Hey, Augustine? All right, Augustine you have to unmute yourself okay. Well, let's go on to Catherine. Catherine, where are you and what would you like to do to advance dental access?
I'm Catherine Meyer-Vanacek. I'm faculty at the Creighton School of Dentistry. I am the course director for the Dental Public Health course and behavioral science aspects of care. Recently, Nebraska took the cap off of the Medicaid benefits. So we are kind of having a little experiment here. It used to be $750 a year. So the dental students are excited about that in many ways. In other ways, they're not because there are some services that are not covered, like metal-based partials and some other things that they really see that their patients need. So perhaps that would be a way to advance the benefits, is kind of covering more of the services to be on par with what private dental insurances are doing. Many of the barriers are that we are the only place that seems to be accepting patients that are on the Medicaid plans from Iowa as well. Iowa did a change recently, and I think that the practitioners did not re-sign up for the Medicaid programs. So a lot of people who are coming to the dental school are saying that no one else accepts their insurance. But sometimes we do have to say no because the patients are very complex for a dental student and just difficult for a learner, especially the first time in the clinic, to work, solo, and then also with someone that may need and deserve faster appointments and quicker care.
Wow, that's awesome. Of course, my first thought is that if they capped it at 100, you had a program, but they capped it at 150.
Oh, sorry, 750.
750.
Yeah,
Okay.
yeah, which is still pretty low when you consider needs,
Yes.
or if anyone needs a root canal or anything, or what teeth they're, covering if you do need a root canal. So this will be a change because they've removed that cap. But the students have let me know that they're not getting services that they've planned because the program doesn't cover it. That's pretty typical for all insurances, dental insurances, hey, that doesn't pay for that. So we'll see if this helps people.
Yeah, and so in each of your cases, it seems like at least you're not starting from, zero. I
Right.
mean, you don't have something, and so the questions I'm hearing, and let me see if this makes sense to you all, is, there's limitations, that on the funding level. There are limitations that the provider rate to provide the dental care is too low to, access dentists. And this was a really interesting thing about, only the dental school. There's only one accepting essentially Medicaid patients.
Right. And I think what happened with the Iowa programs, I'd have to learn more about it, is that they changed who was managing the plans. And so it may have been one of those things that, like, you have to opt in again. And we all know how those work. That becomes a barrier if you have more paperwork to fill out, or different things to do. So it just didn't maybe happen. And so then they're not providers anymore, the dentists that were in Iowa. And here in Omaha, we're on the border with Iowa. So we do accept both Iowa and Nebraska Medicaid plans. And we are getting people from both states and even South Dakota and pretty far away at the dental
Wow.
school.
Wow. But in a sense, those are Medicaid issues rather than dental issues. Linda, you have your hand up. Let's go to you, Linda.
Yes, so I heard you talking about Texas and the difficulties, and I understand that. I know as a hygienist, they were one of the last states, and maybe the last state, that allowed dental hygienists to do local anesthesia.
Mhm.
So, and I know, and I was surprised to hear, not surprised that you have kind of a one-party system there, but surprised that I'm sorry that I'm not showing myself. I'm actually, this is very California. I have a brand new grandson, and they are gone to the doctors, and I have an injury, so I'm in the jacuzzi and I'm in a bathing suit. So I'm nursing my
on.
in the jacuzzi. So very California. Anyway, so that's why I'm not showing myself. But but here in California, we do have federally qualified health centers. Do you have any of those? Do you take any
Yes.
federal dollars? You do have those and healthcare centers.
Yes.
And so my approach to this, I'm in an advocate situation for our political action committee for the state. I'm also on my dental hygiene association, and we're always trying to expand the scope of practice for the the scope is pretty broad, but our dental association is kind of holding us back a little bit as far as placing in rural areas, opening practices. We're allowed to, but if a dentist does move into this area, now they want to take away that rural practice from the dental hygienist and alternative practice. The point is that we are making progress, but very slowly, and still we have huge populations. And as far as the Medicaid benefits, we are accepting some, but there's never enough dentists to, so my approach is to do it from the prevention side with silver diamine fluoride and fluoride and such, preventive side, dental sealants, etc. I directed a dental van for 10 years when through the USC that would go to the local schools. I feel like, I think they did this in New Zealand years ago. I would like to see dental hygienists, have in every school to do all the prevention work. Down the road, it would help with these adults that cannot get the care that they need. Maybe, at least it puts that in their mind that this is very important. So
It is. And so I'll start with you, Donna. So this is a question I'm gonna ask to our three here. So Donna, you mentioned about you have issues finding dentists that'll do it and Medicaid, but I wonder if there's an understanding in your policymakers that, and this is proven health economics, that providing a preventive dental program is actually saving public dollars because it prevents all these worse things. And in a sense, saying that, they won't raise the provider rate enough to get dentists to do it, they're actually, may I say, cutting off their nose to spite their face, to use an old expression. Does that make sense to you, Donna?
It does. I think we have managed to drive home the cost effectiveness of providing preventive care pretty well as far as, well, I don't know about this legislature this session we just had, but in previous years leading up to getting them to pass that adult Medicaid benefit. But I think Medicaid throws some barriers in, like someone else was saying, in that
Yes.
just because you accept Medicaid for kids doesn't automatically make you a Medicaid for adult provider. So I think there's extra paperwork that has to be done, which gives, dentists the opportunity to think, do I really want to do that? And they may opt out of taking that role on. Also, I think, I don't know how it is in a lot of other places, but here, the socioeconomic standard is really low. The education, we're last in education in the country, I just read. So yay, go West Virginia. I think the caregivers of some of our disabled population just have so much to deal with that dentistry takes a backseat to everything else. So I think more integrative care with medical dental, where a hygienist could be in an alternate setting in a medical office, as opposed to having to be strictly dental, would help be able to provide that care when the patient's coming in for other reasons, not strictly for dental.
Excellent point. That's kind of like the FQHC comment that was earlier there. So let's go back. So Augustine never said, so let's go back to you, Catherine. Have you, I mean, you said, basically this dental school is the only one taking the dental benefit. Do the policymakers there understand that it's really cost effective? I think are we losing our
Oh, we
breakout?
lost our breakout.
Okay, well, you know
We're all
what?
headed back.
Okay, well, I can tell you my breakout had a very lively discussion. So, and by the way, when you do something like this, what you hope for is people's thoughts become stimulated and what are the other issues they deal with. And we heard a number of tangent issues, but so this is going to be a bit of a debrief. Let me make sure how much time I have here to do this. Not very much. So, okay, who's going to volunteer out of, say,
Do we
to
have
do some-
everybody back? Just wanted to make sure we've got all the folks back from
You
rooms, Dennis.
should. It looks like it. Yep.
Okay,
Okay.
cool.
Okay, so who wants to lead off on what they discussed in their breakout room? Let's have a
I'll
volunteer.
bring
I'll
something
go.
up real
Oh,
quick.
sorry. Go ahead,
Oh,
Chase.
Oh, sorry. Gary, right at the end, we didn't get a chance to answer it. And Dennis, this is probably something you can even answer better. What do you do when the state you're working in doesn't even recognize it in 1115 waiver, or reaching that out? Gary, do you want to, because that's New York, it might be I know they're all different for each state, so.
Yeah, so I mean, it's just the question is, we got the challenge of access because of that chart with the number of providers, but then the state, is doing the 1115 waiver amendment, gets $7 billion from CMS, and they set it up with, like in New York, the focus is on the health-related social needs and health equity, but nowhere in it is dental included. And it just, to me, it makes no sense. So it's like, how can we change that dynamic so that dental isn't like sitting out on an island of its own, so that it gets funded and the resources become more available to make it more attractive, right, for dentists to participate, because the dollars could be flowing for, and Chase, you mentioned it too, with all the, the social barriers of, people going in for a job interview who are missing teeth, and the biases and just the other economic implications. So that was my thought, right, initially. So.
Well, and what I would say to that, Gary, is you're in the right place. I mean, this is, over the course of these 4 webinars, you should get a roadmap. And this is a policy issue. This is a public policy issue. And you should, and this is crazy to me that the waiver level services don't include dental, because those of you that may not be familiar with the waivers, these people are considered institutional level of care, more complex situations. So I do think it's an advocacy issue. We have just a few more minutes. Who else wants to talk about what they spoke about in there? Is Rachel, you want to talk?
Yeah, I'll jump in. So we talked a lot in our room about, number one, we talk a lot about, in general, member abrasion, how it can be difficult, especially here in Texas. Once individuals turn 21, they don't have the dental benefit. And unless they're on a 1915C waiver or I waiver, they don't have, it's a very limited dental waiver benefit. So we talked about how, someone's dental care has to be really bad in order to end up at the ER. And like we talked about in the main room, the ER is not the best place to treat a dental issue. It's just going to cover up those symptoms for a little bit. So we talked about member abrasion, but we also talked about provider abrasion. So at least here in Texas, it's very difficult. It's a cumbersome process to get credentialed as a Medicaid provider. So not only do they have to be credentialed as a Medicaid provider, then they have to become contracted with that particular health insurance company or managed care organization. So we talked a lot about how can we make it easy for providers to become credentialed in Medicaid and then once they become credentialed, what can we offer as an MCO incentives for us to have good dental providers? So, and anyone from my room can jump in because we talk about a lot, but I think I'm missing a bunch as well. But just a whole gamut of, the ultimate solution for Texas would be have the dental benefit carved in for folks over the age of 21. But if we can't do that now, what are some things to make care easier access to care, whether it be increasing waiver dental funds or just proper education about dental care to avoid going to the hospital or the ER for what could be a dental visit.
That came up in the breakout I was in too, is just that there are issues that are Medicaid issues, not necessarily Medicaid dental. And the two that, and you touched on that one, becoming a provider is paperwork heavy, and it's a lot of work. And even if you're like providing dental care to kids, it doesn't mean you're qualified to do it for adults. And then if you do, the provider rate may be very, very low. We had people from California, West Virginia, Nebraska, the whole, right across the nation. And every one of them had some reference to, underfunding, even though we all recognize that it's your public dollars invested will return more than the cost of the dental care. So this is still an advocacy issue going forward. Anyone else that has comments?
Yeah, and I just wanted to add to that, ER visits and hospital admissions are going to drive up the cost of healthcare. So if we decrease those, we're helping out in all facets. And I have to brag, in our room, we had someone, Rima, from the United Kingdom. So I don't want to put her on the spot, but we had an international.
All right.
Yeah.
Well, anyone else? Okay, I have a few notes from ours, and I'm going to turn it back to Liz to close this out. But it was very lively discussion. Again, some of the things we heard about, out of California, again, they wanted to have, a scope of practice for dental hygiene. Genus could be expanded, which is more affordable. They wanted to have more mobile dental clinics. In West Virginia, the adults have recently gotten a dental benefit, but very few dentists will actually do it for the provider rate, and the barriers already endemic to Medicaid. Nebraska, this was a really interesting one. Creighton School of Dentistry there. They get Medicaid, they accept Medicaid patients, and they get them not only from Nebraska, but from surrounding states, because no one can find a dentist that'll take them on for that kind of money. And yet, not all dental students are going to be qualified to provide more complex dental care as needed by people who have not had access to a dentist for a number of years. Quick story. Jeff Brunson, when I referred one of our members to him, a person who had not seen a dentist in 15 years, that person had to have 8 teeth pulled. Okay, complex needs that have been overlooked for years. This, again, when only the dental schools, only people that are going to provide the care in a multi-state region. There are problems, folks, but instead of taking it lying down, let's fix it. I'm going to kick it back to Liz to close us.
Thank you so much, Dennis. And thank you everyone for participating in such a dynamic conversation. It was really wonderful to be a part of. So as I said at the top of the call, we are offering continuing education credits for this call. You can get that by filling out our CEU request form, which Rahel is going to put in our chat here, and it will also pop up at the end of this call. Also, part of that form is our evaluation link. We encourage everyone to participate in the evaluation link, whether you're requesting CEUs or not. It's very helpful to us to ensure that we're developing out these tools that are a part of this program so that they're as useful as possible. Again, this is the first session in a 4-part series of training webinars. So we hope you'll join us next time. So we're going to pop in the registration link for our next webinar, which is on May 1st. So we'll pop that in, and we'll also be emailing out recording and resources from today's session. So again, please grab those links. We hope you join us next time. We hope to hear from you as we're building out these resources for this program. And thank you all for being here. We'll see you in May. Take care, everyone.